Hi there, my name is Narendra Kaur. This is for my FNP597 Signature assignment. Case description. BG is a 27-year-old male who presents with abdominal discomfort for the past few months. Clinical site is Kaiser Foundation Hospital's family practice in Elk Grove, California. The reason that I chose this case is because abdominal pain is a very common diagnosis in family practice, and knowing the right resources can help diagnose the condition. I spent a lot of time with this patient discussing his symptoms, the different interventions, the different diagnoses, and what we could do to help him improve his lifestyle. Also, in the past, there's been a rise in gastritis, GERD-related issues due to alcohol, also with a rise in mental health disorders. It's also relating to a lot of IBS and abdominal pain. So as a provider looking for the right symptoms can help guide a patient's diagnosis. Case presentation: BG is a 27-year-old male, Caucasian male. His CC is that I have been having stomach pain for the past few months and it's not getting better. His HPI is that 27-year-old Caucasian male presenting for abdominal pain. It's been ongoing for the last 4 months. He goes to the bathroom every time he eats. He says it's more after spicy foods. He can go 1 to 2 times a day. For bowel movements, it can be loose diarrhea or normal. He also reports that he's having stomach issues like bloating, gas, regurgitation, burning in the mid-chest area, burping, stomach pain, and diarrhea. He has tried Tylenol, ibuprofen, Pepto-Bismol with no effect. Right now his pain is a 7 out of 10 to the mid right abdomen. It's worse after eating. The pain comes and goes. Also, he wants to be tested for STDs as he thinks his partner is not sleeping around with other people. Denies bloody stools, chest pain, vomiting, no fever, chills. Past medical history: allergic rhinitis, major depressive disorder, insomnia, substance use disorder, claustrophobia. He does not have any recent surgeries or hospitalizations, allergies to pollen, but he does not have any food, drug, or latex allergies. Medications that he does take are trazodone, 100 milligram PO, every evening as needed for insomnia. Sometimes he will take Motrin for pain. He's up to date on his immunizations. Family history: father 50 years old. He does have controlled hypertension. Mother 45 years old with no chronic conditions. He does not have any siblings. Social history is that he was sexually active with his girlfriend for the past few months, but he thinks that she's sleeping around with other people, so he wants to be tested for STDs as he thinks they could be contributing to his symptoms. Patient did drink alcohol for nearly several months. He has been sober for a year now. He was drinking hard liquor. He did smoke with his friends on occasions. He did smoke cigarettes and marijuana. He has not done any smoking for the past 2 years. Chemical history: patient has tried different drugs in the last 10 years, but he has not tried anything for the past year. He did try cocaine, marijuana, or whatever his friends were doing. Right now he works at a auto repair shop, his dad's friend's auto repair shop. He's been working there for 6 months. Patient lives in an apartment. His eating habits are not as good, as he eats a lot of fast food. He does not cook any meals at home. The only home cooked meals he has are when he goes to his dad's house. Otherwise, it's frozen foods, store-bought from restaurants. He eats a lot of spicy food like Mexican or Thai, a lot of burgers. He has about 2 cups of caffeine. He does not have an accurate schedule for his food intake, as he can sometimes go a day without eating, or then he can be eating all the time. He does go to the gym regularly. Review of systems was negative, unremarkable. The only thing he reported was abdomen pain and diarrhea. He also has a history of depression, alcohol use, and substance use. He does have sleep disturbances. For his vital signs, everything was within normal limits. His BMI is 20, height 6'6", weight 180. Physical exam was unremarkable. His abdomen was soft, non-tender. He did have generalized tenderness to the mid-epigastric region, negative Murphy's, negative McBurry's point, negative CV tenderness. His speech was a little bit fast, but otherwise he was appropriately dressed. He was not withdrawn. For our assessment, the diagnoses that we came up with were GERD, gastritis, and IBS. The reason for these was that based on the patient's history of abdominal discomfort associated with eating, gas, his bloating symptoms, regurgitation, and diarrhea, we narrowed it to those three differentials. But the symptoms do not strongly imply an infectious cause, but the patient's concern about STDs and gastrointestinal disturbances warranted us to check him for H. pylori, other infections. Also, given the chronic nature of his symptoms, lifestyle factors such as diet and stress are likely contributing to it. That's why we thought about gastritis as well, due to his history of alcohol, NSAID consumption, stress, and IBS as well, due to his history of depression. But the reason we went with GERD was more because of the symptoms, heartburn, regurgitation. His location of his symptoms pointed more to GERD. Our plan included testing him for stool studies for H. pylori, making sure that's treated if that is the cause. Other lab work for ova, cysts, and other enteric panels that may be causing the diarrhea. Electrolyte panel, kidney function, just to make sure everything is in balance. Liver function test. Patient also wanted to test for STI, so we're gonna check for chlamydia, gonorrhea, hepatitis B and C, HIV. We're gonna prescribe him omeprazole, 20 milligram tablet daily before breakfast, 30 minutes. And he's going to take that medication after he has provided stool samples. The therapeutic plan is discussing the lifestyle changes for GERD as avoiding, limiting alcohol, caffeine, spicy, acidic, citric, and fatty foods, eating smaller meals throughout the day, continuing not to smoke, continuing not to drink, maintaining a healthy weight, sleeping on extra pillows, providing the FODMAP list to help with symptoms that could be contributing, adhering to medication regimen, and stress management. The resources that helped us was with the Kaiser website. We have the e-consult to GI, and with their, before he can be seen by GI, we need to make sure that he has the interventions for the lifestyle changes. He's following the food to see if the GERD diet or if the FODMAP diet, if there's any foods contributing. If he has tried the PPIs for at least 8 weeks before he could be seen by GI. So we talked about that. We educated him about that. Our follow-up is that he's going to be returning in 1 to 2 weeks to discuss lab results. If H. pylori is positive, treating him for that. If STDs are positive, treating him for that. If lab studies are negative, we're going to continue the medications and have him return in 4 weeks and see if there's a change with the dietary interventions, pharmacological interventions, and if it's not resolved in 8 weeks, he will be referred to GI. Evidence-based practice for this is his presenting symptoms are for GERD, and for GERD, the first line of treatment is the prescribing PPIs, the lifestyle changes. Testing for H. pylori is important as it can also mimic symptoms of GERD, of ulcers, and then talking about the FODMAP diet is important because it's leading to IBS. Our holistic approach with this patient was making sure we provided a holistic approach addressing his physical symptoms, his physiological well-being. We talked about his fears about the potential STDs as they're more of a deeper anxiety and emotional distress. I made him where he was in a comfortable place and he was able to validate his concerns and ensure that he was being heard. I used Gene Watson's theory of promoting and accepting expression of positive and negative feelings and allowing him to talk about his feelings because he was concerned that his partner's infidelity, how it's making him feel. So just allowing him to talk about it in a positive way. That way he could express his feelings. As Gene Watson stated, there's no right or wrong feelings. It's just that's what they are. Also incorporating Gene's curative factor of developing a helping trust relationship to ensuring that he has a safe space where he can openly communicate. Having that special relationship is important because I'm trying to provide him space where he can openly communicate about his symptoms and concerns without being judged. Also collaborating with the dietitian or with the to do the appropriate nutrition and lifestyle changes, also including his family member to help him or his roommate to hold him accountable for his care plan, and also talking with a behavioral health psychologist for cognitive behavior therapy to see if he also needs help with that. I try to provide a lot of holistic care where I try to look at his medical aspect, also his emotional aspect, to make sure that we're trying to provide the best care and try to make a fostering trust to provide best outcomes. Thank you.